John Bernabe. I'm an MD PhD student at the University of Pennsylvania, originally from Michigan. My fun fact is that I once flew a propeller plane with supervision. Uh, this research project is something I did during my thesis with Dr. Brian Litt. The title is Normative Intracranial EEG Maps Epileptogenic Tissues and Focal Epilepsy. So epilepsy surgery is often guided by recording seizures directly with the goal of defining the epileptogenic zone, which is a region from which seizures can originate. That's done by a qualitative interpretation of intracranial EEG. And then that zone is targeted either with surgery or neurostimulation with the goal of hopefully making the patient seizure free. Unfortunately, even when clinicians feel like they've defined the epileptogenic zone well, many patients don't achieve postoperative seizure freedom, particularly those with disease outside the temporal lobe. This points to our incomplete understanding of how seizures arise from an abnormal brain, as well as the fallibility of relying too heavily on seizure recordings and the need to develop quantitative tools to aid in selecting appropriate surgical targets. So our overall goal in this project is to develop a quantitative approach to guide epilepsy surgery from interictal intracranial EEG recordings, which are taken when their patients at their baseline between seizures. And we hypothesize that brain regions which can generate seizures have abnormal neural activity and interregional connectivity at baseline. So in this project, we're assessing neural activity by quantifying the proportion of signal power in each canonical frequency band representing different physiologic oscillations. And then we're estimating connectivity between regions by quantifying the correlation in frequency content between pairs of recordings from separate electrodes. And so our first step to mapping these abnormalities in activity and connectivity was to construct a normative intracranial EEG atlas. This consists of, it's just short recordings from over 2,300 channels in 144 patients. And these were taken from electrodes implanted in tissue that was clinically judged to be normal, meaning that it didn't generate any epileptiform discharges or seizures, or it wasn't lesional, over the course of the patient's stay in the epilepsy monitoring unit. We then mapped all of these channels to different brain regions, over 40 different brain regions, because we know that patterns in neural activity and connectivity vary anatomically. And so the overall goal here is that by comparing recordings from new patients that we're interested in to this normative atlas, we can see which regions have abnormal patterns in neural activity and connectivity, which then may be implicated in regions that are most important to target surgically to leave the patient seizure free. So I'll show you how we do this. We did this in 60 patients. So for each electrode contact in each patient, here an example patient with the kind of brown recording, that was from an electrode in precentral gyrus. We compare the frequency content in each of these kind of 5 canonical frequency bands to that of over 50 channels recorded from the same region across patients in the atlas. And then we generate z-scores representing how abnormal the observed frequency content is to the expected frequency content. We take a similar approach for connectivity, here looking at pairs of anatomic regions and the connections between them, again generating z-scores for the patient's connectivity data compared to all the connections observed between those regions from the normative atlas, again generating these z-scores of how abnormal the neural connectivity patterns are. And then what we do is we feed in all of these z-scores representing activity and connectivity patterns into a machine learning model to identify and predict which regions are most likely to be able to generate seizures. and that we call predicted epileptogenicity. And so to kind of gut check our overall method, we observed that uninvolved brain regions across patients have the lowest predicted epileptogenicity. Regions which can generate epileptiform spikes but not true seizures have a higher level of epileptogenicity, and then the seizure onset zone regions have the highest level of epileptogenicity across patients. So the final thing I'll do is I'll show how we could potentially use a method like this to inform surgical planning. So on the left, I have a kind of diagram of a patient that achieved a good surgical outcome and was seizure-free, and I'm showing seizure onset channels from their ECOG grid in red, spiking channels in green, and uninvolved zone in blue, with the resection outline here in pink. And from these recordings, we calculated our abnormality scores across neural activity and connectivity, and then predicted epileptogenicity, with red being most epileptogenic. And we can see that these red and yellow and orange overlap well with the resection zone. And then here's a patient that unfortunately didn't become seizure-free, and we can see that they had a mesiotemporal laser ablation. However, in the contralateral mesiotemporal lobe, there were some highly predicted epileptogenic channels. And so plans like this could potentially be useful in guiding surgeons towards what therapy to use and what surgical targets to pick. So overall, epileptogenic brain regions manifest abnormal neural activity and connectivity compared to clinically normal channels. And this normative intracranial EEG mapping can identify potential surgical targets without the need to directly record seizures. I'd just like to thank our multidisciplinary team in neurology, bioengineering, and neurosurgery. And here's our kind of recent paper on this topic. And I'd like to thank all of you for listening and for a wonderful sub-internship experience. Thank you.
So that was great. And I know there are one or two people in the audience that know little about EEG and seizures. May I ask if there's a question from any of those folks? Dr. Ojiman Jr., not George. Jeff?
Yeah, thanks. I hope you see my hand there.
I do.
No, that's good stuff. And my question is, do you think you can see this in the functional MRI data that you might get from these folks pre-op? Because it's really intriguing what your group's finding, especially with the normative. It isn't clear to me if that will cross over to other modalities or not.
Yeah. So there's been a lot of great work on fMRI and like diffusion tensor structural MRI on this, and actually a lot of the findings that we have here mirror themselves very similarly to those other modalities. So certainly we're kind of picking up on a common signal, and so these results actually recapitulate themselves quite well elsewhere. The reason that we kind of favor this approach a little bit is because the kind of anatomic granularity of intracranial EEG is perhaps a little bit better than fMRI. So you would have these sort of predicted epileptogenicity maps at the same spatial scale as your electrodes, and so that may be a little bit better for clinicians than just looking at kind of broader regions, but certainly the same signal is present throughout.
Great. Any other questions? Oh, wait, let's just do one more, and I apologize. Nino Ramirez, sorry, Jason, and it's not anything personal against any of the other two.
Oh, no, we should have asked Jason, but I was, first of all, amazing figures, and secondly, did the connectivity change over time? Like, I mean, were they like that you could recognize?
Yeah, a great question. And so we tried this. This was actually done with small, short clips of only a few minutes. And so we tried kind of sampling across the week or two that patients were in the EMU. We found that the areas that were predicted to be epileptogenic were pretty consistent as long as you had the patient was far away from any seizure, so that didn't kind of, pre or post ictal states didn't really influence this. And we made sure that we picked time that was further away, at least a few days away from the day of implant, so that those initial kind of inflammation and implant effects weren't a factor. But if you don't do that, if you select away from those regions, then it's relatively stable. Thank you.
Great. All right. I apologize for the other scientists that had their hands up. You can talk offline. John, excellent talk. Our next speaker is...
Matt will be speaking next.
Thank you. My other brain is Megan. So thank you, Megan.
No problem. We'll give Matt just a minute here.
Yeah, Matt's just getting...
And Dr. Elving, just so you're aware, some of our sub-Is are a little bit space constrained today, so they're doing a little bit of switching in between. So I think that's just what's going on. Switching spaces.
No worries. I don't want to make them more nervous than they are. Take your time. Okay.
Yeah, sure. No, thank you, Dr. Ellenbogen. Let me just share my screen here. Yeah, we're just switching out of the call room.
Yeah,
that's what just take.
Yeah.
A minute. Can everyone see my screen?
Yes, we can. Thank you very much. Thanks, Matt.
Excellent. So yeah, my name is Matthew Hagan, and I am a visiting student from Brown University. And my interesting fact is that I ran the Boston Marathon at age 18. So first, I would like to thank the entire Department of Neurosurgery here for granting me the opportunity to come and perform an away rotation at your institution. My presentation is entitled Socioeconomic Status and Disproportionate Healthcare Utilization Following Elective Spine Surgery. So as we know, healthcare systems face increased financial pressures. These financial pressures are multifactorial, but partially due to an increasing number of patients with Medicare or Medicaid that do not reimburse as well as private payers, as well as a changing hospital reimbursement structure landscape. For example, an increasing amount of payers are focusing on bundled payments, which are a method of reimbursement for which a single comprehensive payment is made for a solitary acute care episode. We also understand that a small number of patients contribute to the majority of healthcare expenditures. Specifically, the top 10% of healthcare users make up 65% of total healthcare spending. We also know that inpatient hospital beds are expensive. An inpatient hospital bed can cost more than $2,500 a night. Thus, appropriately reducing inpatient length of stay can be expected to improve hospital financial solvency and enhance clinical outcomes by reducing nosocomial pathologies. Area of Deprivation Index, or ADI, is a locally sensitive tool that assesses income, education, employment, and housing quality in a specific neighborhood using 9-digit zip codes. ADIs are national percentile rankings with a score of 100 being the most disadvantaged, a score of 1 being the least disadvantaged. As you can see on the map of Rhode Island at the left, the blue areas represent less deprived areas, and the areas of red represent more disadvantaged areas. And here's a map of Seattle. ADI is calculated by first converting patient's street address into a 9-digit zip code. This 9-digit zip code is then converted into a national percentile ADI ranking. Healthcare resource utilization is particularly germane to neurosurgery, as these procedures are often among the hospital's most profitable. Additionally, the volume of spine surgeries in particular is increasing, and thus identifying patients at risk of increased healthcare resource utilization prior to surgery is a valuable opportunity to develop targeted pre- and perioperative intervention and quality improvement initiatives. In the present investigation, we sought to identify risk factors that predispose patients to prolonged length of stay following elective anterior cervical spine surgery, employing a novel representation of neighborhood-level socioeconomic status, namely ADI. And we hypothesized that there would be disparate length of stays in between socioeconomic groups. To do this, we employed a retrospective cohort analysis as our study design. Our population was patients who underwent an elective cervical spine surgery from the years 2015 to 2021. Our study outcome was extended length of stay defined as greater than the 90th percentile for the study population, or 3 or more midnights. Our secondary outcome measure was emergency department visit or readmission within 30 days following discharge. We adjusted for a number of sociodemographic, procedural, and hospitalization characteristics. Specifically, ADI was dichotomized into the highest 15%, the highest deprivation, and lowest 85%, the lowest deprivation. And we performed a multivariate logistic regression to predict extended length of stay. Overall, 686 patients met our inclusion criteria and were included in our analysis. Results from our multivariable logistic regression are shown here. And we found that most disadvantaged patients on ADI were more likely to have a prolonged length of stay. The figure on the left demonstrates this in graphical format. Interestingly, patients with an extended length of stay were more likely to represent to the emergency room or be readmitted within 30 days following their discharge. And the most common reasons for ED representation or readmission were pain, concern for a new neurological deficit, or a wound issue. Prior literature has identified age, gender, and pre-surgical comorbidities as predictors of postoperative complications and a prolonged length of stay. Other studies have demonstrated that patients with Medicaid and those identified in minority racial groups are more likely to have a prolonged length of stay following spine surgery. Potential solutions to assist patients at potentially unnecessary healthcare resource utilization do exist. For example, patient navigators help coordinate care and attenuate social pressures. This assistance has previously been shown to lower length of stay following elective surgery for high-risk patients. Another potential solution is enhanced recovery after surgery program, which has been found to reduce length of stay, accelerate return to function, decrease costs, and improve postoperative pain. Lastly, highly disadvantaged patients may uniquely benefit from these resources where patient navigators in ERAS can only be offered in a subset of patients. This is an example of what a potential integration of this research may look like. This is a screenshot of ICU readmission and mortality risk presently with an Epic. Ideally, extended length of stay would appear as an Epic dashboard when booking a patient prior to surgery. A notification would alert the physician, mid-level, or administrator that a patient is at increased risk of prolonged length of stay. This may automatically set the patient up with a patient navigator who can submit for prior authorization prior to surgery and set up ERAS, which may expedite their discharge and reduce inpatient length of stay. The present study is not without limitations. First, the present study was at a single center. We did not detect or correct for preoperative functional status, surgery indication, or disease severity. And lastly, ADI itself is a composite of multiple social forces, namely income, education, employment, and housing quality. And there's unlikely to be a single driver of extended length of stay. In summary, disadvantaged patients, as measured by locally sensitive metric of socioeconomic status, are more likely to require more health care resources following elective spine surgery. These patients can be identified pre- and perioperatively, engendering the opportunity for intervention aimed at attenuating pressures and may be causing them to stay in the hospital longer. We're fortunate enough to publish the present findings in World Neurosurgery. I would just like to thank my co-authors in the Department of Brown for supporting me through this research. And I'm happy to take any questions, and I also have my references below.
Thank you very much. Any questions? I'm just going through the pictures. Anybody? Speak up.
I have a question.
Go ahead.
If you're looking at reducing costs, the single most important factor would be eliminating the surgery. And I don't know about the details in the Providence, Rhode Island area, but the United States does more surgery per capita than any country in the world, from which you could surmise the American back has failed, or you could suggest that perhaps the indications for doing surgery in our country could be modified, and that would have a bigger effect on costs than what you're talking about.
Sure. Yeah, I mean, I think this, probably an assumption of this study is that these are the patients that meet, surgical indications for surgery. But so I'm not sure we're necessarily asking ourselves the question, would these patients have benefited from non-operative treatment? I would suspect that the majority of the 686 patients did try conservative management first and failed that, and that's why surgery was suggested.
Good, thank you very much. That's John, I expected you to ask that question. That was
At least I'm predictable.
well, yeah, I mean, it's an important question. All right. Thank you, John. Appreciate it. Next person up, please.
I'll have Gabby.
Gabby?
Yes. Can you hear me? See my screen?
Yes, Gabby, I can. And I didn't call you Gabrielle. So I got it right.
Yeah. So my name is Gabby. I'm visiting from WashU in St. Louis. And my interesting fact is that I used to do competitive cheerleading. So I used to be able to do kind of all those flips and stuff that you see with both cheerleading and gymnastics.
Wow.
But today I'll be talking about moving towards rational use of repeat neuroimaging in children with mild traumatic brain injury and intracranial injury. So pediatric mild traumatic brain injury, or MTBI, is both a common and costly diagnosis with annual inpatient charges totaling over $1 billion. And while many clinical decision support algorithms exist to determine which patients should receive initial cranial imaging, there's less evidence-based guidance for the management of those patients with mild traumatic brain injury and evidence of intracranial injury on imaging. And while surveillance imaging is a relatively common practice in these patients, prior literature has suggested that it rarely leads to changes in clinical management, and thus this utility remains controversial. And while appropriate use of repeat imaging can allow detection of patients at risk for neurologic decline or needing neurosurgical intervention, it comes with costs such as increased radiation, increased hospital length of stay, and increased cost of care. And for this reason, effective risk stratification can focus repeat imaging on patients most likely to benefit, improving hospital efficiency and limiting preventable harm. So the objectives of our study were to, one, identify factors that are associated with patients undergoing repeat imaging, and to also identify predictors of hemorrhage progression and or neurosurgical intervention. So to do this, we leveraged the Pediatric TBI Research Consortium database. All patients included in this cohort were age 18 years or younger who presented to one of 4 participating emergency departments within 24 hours of blunt head trauma, with a Glasgow coma score between 13 and 15 on arrival and evidence of intracranial injury on index imaging. Our 2 outcomes of interest were, 1, whether patients underwent repeat neuroimaging during admission, and 2, a composite of neurosurgical intervention or progression of previously identified hemorrhage greater than or equal to 25% in maximal dimension. And in all cases of neurosurgical intervention, repeat imaging findings were reported in the operative note or electronic medical record as an indication for the neurosurgical intervention. So we performed univariable logistic regression to first identify candidate factors associated with our outcomes of interest, with subsequent backward stepwise multivariable logistic regression to identify predictors while controlling for the effect of the other variables in the model. And in our original cohort of 1,324 patients, 41% of them underwent repeat imaging. And of these 547 patients, 10% reached their composite outcome. So for our overall cohort, the median age at presentation was 4 years, and the majority of the cohort was male and white. The most common clinical presentation was vomiting, which was present in 31% of our cohort. And the majority of our patients presented with a Glasgow coma score of 15, with only 5% of our cohort presenting with a Glasgow coma scale score of 13. 13% of our patients presented with significant non-cranial injury, and 9% presented with concern for non-accidental trauma. And all our patients presented from 4 institutions. So of the 547 patients that underwent repeat imaging, 23% of these repeat images were MRIs. The repeat imaging was planned in the vast majority of cases and was only performed due to changes in clinical status in 5% of our patients. And there were new traumatic findings in 13% of repeat images and hemorrhage progression in 10%. And the most common new imaging findings were contusion and subdural hematoma. Repeat imaging findings were cited as an indication for neurosurgical intervention in 14 patients, or 3% of these patients. And of these patients, 80% of them had an epidural hematoma on initial index imaging. And similar to our overall cohort, the repeat scans were planned in the vast majority of the cases. So we then tested for a variety of clinical, radiographic, and demographic factors to identify those were associated with patients undergoing repeat imaging. And overall, over 15 factors met our threshold for multivariable regression. And after this multivariable regression, we found that the presence of intraventricular hemorrhage, epidural hematoma, cerebral edema, extraaxial hemorrhage, and subdural hematoma on index imaging were independently associated with patients undergoing repeat imaging. And in terms of non-radiologic variables, we found that assault, concern for non-accidental trauma, and post-traumatic vomiting conferred a higher odds of patients undergoing repeat imaging in our cohort. And interestingly, we also found institutional variability within our cohort, with one institution having a higher rate of repeat imaging and the other having a lower. So we also looked at predictors of the composite outcome of neurosurgical intervention or hemorrhage progression. And with multivariable analysis, we found that only the presence of epidural hematoma, age 2 years or older, and post-traumatic seizures conferred increased odds of the patients undergoing neurosurgical intervention or hemorrhage progression. Patients with epidural hematoma on index imaging had a 4 times higher odds of experiencing composite outcome, while patients with post-traumatic seizures had a 3 times higher odds of experiencing the composite outcome. Sorry. And then also, while looking at patients all of our patients who developed the composite outcome, we found that 91% of them had at least one risk factor. And of the patients without any of the risk factors, none of them underwent neurosurgical intervention. So this study, like all studies, has its limitations. Firstly, this data is very specific to pediatric patients with mild traumatic brain injury and intracranial injury, and thus we can't use it to generalize to patients with severe traumatic brain injury or those without intracranial injury. We also acknowledge that the results are impacted by individual variability in decision-making regarding repeat imaging and neurosurgical intervention between both physicians and centers. And this is particularly important given prior evidence suggesting that provider demographics like time in practice and provider specialty may influence decision-making in these patients. And we also acknowledge that many factors contribute to the decision-making process, especially regarding neurosurgical intervention, and we're unable to account for all of these aspects of decision-making in this study. So to conclude, while repeat imaging in this large multi-institutional cohort of children with mild traumatic brain injury and intracranial injury was common, it was uncommonly associated with clinical change, and it uncommonly led to neurosurgical intervention. And while many factors were associated with patients undergoing repeat neuroimaging, only post-traumatic seizures aged 2 years or greater and presence of epidural hematoma were significantly associated with composite outcome of undergoing neurosurgical intervention or having progression of their prior hemorrhage. And while these factors should be validated in further studies, the present results may assist physicians in focusing their indications of repeat imaging on a smaller set of children most likely to benefit. And I'd just like to acknowledge all the members of our consortium. Thanks.
That's great. That's a great talk. Good people, great mentors. Of course, everybody's had great mentors. Any questions from our audience?
Yeah, I'll ask a question. This is Chestnut. This study, like many studies, values CTs only if there are positive findings, change in the intracranial injury index or neurosurgical intervention. It doesn't account for the value of a negative finding. In other words, no progression, improvement, and which can have implications for triage, length of stay, and other issues such as a child with a mild traumatic brain injury and, say, a femur fracture who wants to have his femur fixed. If you know that the brain is stable, you may be much more likely to allow that femur to go off rather than waiting a day for observation. And it's always an issue. It's with all of these studies. And I think there's a lot of value to finding a negative study in terms of triage and patient management. Can you comment on that?
Yeah, so that's certainly an interesting aspect that we weren't considering with this initial study. I would say that it's definitely something that we should consider looking into more deeply, and I'll definitely bring it up to my mentor, Dr. Limbrick. I think that for us, our viewpoint on this was kind of, there's all this evidence to decide imaging versus no imaging, but we don't know what to do with those patients who have something on imaging. And so what does it mean for them, and should they continue to get kind of the surveillance imaging or not? But I think that you raise a very interesting point, and it's something that we should definitely think more deeply about.
Thank you very much. Good question, Randy. All right. Thanks, Gabby. Next sub-by up.
We have Katie up next.
Katie.
It'd be me. Hello.
Hi, Katie.
Hi, so my name is Katie. I am a visiting student from Drexel University College of Medicine, originally from Los Angeles. And I guess the fun fact about me would be that prior to medical school, I started my own calligraphy business because I just couldn't get behind the cost of hand lettering when I was planning my own wedding. And I ended up doing hand lettering events for things like Coachella and the Grammys. So today I'm going to be talking about transplantation of human-induced pluripotent stem cells and how it induces plasticity of the respiratory circuit following high cervical SCI in a rat model. So spinal cord injury is a devastating event. It leads to motor and sensory deficits, of which impaired breathing is one of the most life-threatening. There are 17,000 new SCI cases each year, and over 59% of them are in the cervical region. As recently discovered, ventilator dependency significantly decreases life expectancy. For example, a 20-year-old pre-injury would have a life expectancy of 59.4 years, and after injury, only 9.4 years. So this is a very important topic to study. Some barriers to repair would be the severity of inflammation itself. It can cause dieback of regrowing axons or even damage to spared axons that you can see down here in green. This glial scar formation that creates kind of an impenetrable barrier for these axons to grow across. And even the lesion itself can become cavitary, so there's no substrate for these axons that are trying to regrow towards their motor neuron pools to get through. So how do we overcome these barriers? These are all strategies that my lab has implicated. You can either have an internal scaffolding, such as stem cell transplantation. You can have an external stimulus, such as intermittent hypoxia, to drive plasticity from an external source. Or you can do an internal source of plasticity by doing intraspinal injections of BDNF in those caudal phrenic motor neuron pools to try and pull those regrowing axons towards their target of interest. But today we're just going to be talking about that stem cell transplantation. So a little bit about our timeline and methods. So we started our human iPSC, or that human-induced pluripotent stem cell differentiation 3 weeks prior to injury, and we pushed them towards the neural progenitor cell type. We then induced a C3 left-sided contusion injury, and then 3 weeks later, we transplanted our cells. At 10 weeks post-injury, we performed terminal electrophysiology, sacrifice, and retrograde tracing with pseudorabies virus, which is a retrograde transsynaptic tracer that is able to label the entire phrenic circuit. So any kind of connections that are being made within the respiratory circuit are going to be labeled by this PRV. And so what we found is that the donor tissue fills the lesion cavity. So that cavitary lesion barrier was ameliorated with this transplantation. And so up on the top, you can see in green are human neuronal cells, and in red are rat serotonergic axons, which are regrowing, sprouting, regenerating axons. And then on the bottom, you can see in red is human astrocytes, and in green is rat astrocytes. And if you notice up top, you have this kind of interesting pattern of these serotonergic axons growing into the transplant. And in the bottom, you can see these astrocytes that are almost lining up along that same region to support this growth. And over in A prime, you can see how they these projections kind of resemble these like tubular structures, So we hypothesized that these were vascular in nature, and when we scanned for endothelial cells over here in blue, we found that they were in fact blood vessels. And so we were able to conclude that these regenerating serotonergic axons were growing into the transplant using vascular scaffolding. So our host is getting into our transplant, but what happens once it gets there? Remember that PRV staining, you can see in red, is going to be staining the entire phrenic circuit. We injected the diaphragm, so anything that's getting into the phrenic circuit is going to be in red. And we found this co-labeling of cells within our transplant. And so our transplanted tissue was in fact integrating within our circuit of interest within the phrenic circuit and making connections with the host. And so we wanted to next see if these were meaningful connections. Were they just you know, randomly making the same connections, or was it doing anything? And so we challenged our animals with a hypoxia, which is that respiratory challenge. And up top, you can have our uninjured, naive animals. And you can see with euthymic breathing that they're breathing normally, and then with the challenge, they're able to respond. Injured and untreated animals cannot respond to challenge, but our transplanted animals were able to have some recovery following their treatment. And so we were able to conclude that transplantation promotes functional respiratory recovery. And then, as we mentioned prior, that these transplantations are vascularized by the host, and it's driving that integration from the host, and that they're able to make meaningful connections with the phrenic circuit. And so on my final slide, what does this mean for patients? There was a clinical trial by Shin and colleagues that actually used neural progenitor cells, which is the cell of interest that we were using in 2015. And they found that transplantation in their patients led to a significant increase in motor and sensory scores at 12 months post-transplantation. And it also increased the level of recovery that these patients saw. So they were able to have you know, at 2 levels of recovery in comparison to the controls, which only had possibly 1 level of recovery. And they also had an increased number of 1-level recoveries when compared to the controls as well. And with that, I'll take questions.
That was great. Any questions? Let me go through the screen. I don't see any.
Can I ask the question? I'm sorry, I don't know how to raise my hand.
That's okay. You just opened your mouth. That's perfect.
Okay. Katie, thank you. It's a beautiful talk. I have one question. Did you try the same experiment after injury? Because initially your experiment model was implantation before injury and differentiation. How about if you do it after injury? And a second question is, I know it's appealing to talk about differentiation into neurons. What happens if you use any kind of just you leave the pluripotent cells there and not necessarily push into differentiation? Can they kind of themselves form the scaffold?
Yeah, so it's a great question. So we actually do transplant after injury. We do it 3 weeks after injury to more mimic what we would see in clinic to give the spinal cord a little bit of time to calm down. As far as using just normal non-differentiated stem cells, we have done those experiments. We have found that they're more tumorigenic, so the transplantations that we do will tend to outgrow the injury site and compress the healthy cord that on the contralateral side. And so we decided to try these experiments of pushing cells towards more specific cell types. And so we chose neural progenitor because we wanted all of the cells that came from that lineage, including like astrocytes, interneurons, and all the et cetera.
Great, thank you.
Yeah.
Great. And Ali is the last one. Nali, you're building up. Thank you.
Yes, let me share my screen. Are you able to see my screen?
Yes,
Yes, I'm sorry. Go ahead. Yes, I am. We are.
Okay, great. So hi, everyone. My name is Nali Muthia. I am from University of Pittsburgh. And a fun fact about me is that I only started distance running, when I started med school. So I've made it a goal every year I run a marathon. So I'm coming up on my 4th marathon this November. Other than that, so today I'll be talking about vagus nerve stimulation for drug-resistant epilepsy that is work that I've done out of Children's Hospital Pittsburgh. So a little bit of background, about 1% of the US population has epilepsy, and up to 40% of these patients have drug-resistant epilepsy. So when resective surgery is not feasible, VNS is a potential palliative option. But unfortunately, randomized control data, especially among children, is not really readily available. So the goal of this project, we performed several comparative effectiveness studies to evaluate the safety and clinical outcomes of VNS in the pediatric population. So over the last couple of years, my primary mentor and I have been working to create and maintain a database of pediatric VNS patients from Children's. So overall, we have 365 patients representing 686 total procedures, making it the largest single center pediatric VNS database to date. So our first project was kind of with regards to the effectiveness of VNS for young children with epilepsy. Today, VNS is FDA approved for focal epilepsy in children greater than 4 years, but we found that a similar proportion of patients 0 to 3 and 4 to 6 responded to VNS, and this was still true even after we excluded difficult to quantify seizures like myoclonic seizures, absence seizures, infantile spasms. And at 4 years, you can see here that most seizures actually did decrease in frequency, specifically focal impaired awareness seizures. So then we started thinking about different models of VNS. Newer VNS models like closed loop models, which stimulate the vagus nerve in response to tachycardia, became the new standard VNS model available at most institutions, including our own. I performed a propensity score analysis to compare patients who had traditional models, these fixed stimulation cycle models versus closed loop models. And we found that after 2 years of therapy, closed loop VNS models allowed a larger proportion of patients, specifically those with generalized epilepsy, to achieve VNS response. And I think this is interesting to consider in the context of closed loop VNS physiology. It's possible that patients with generalized seizures responded better to closed loop models just because they tended to experience ictal tachycardia more, but that's just a hypothesis. So we then became interested in predicting response to VNS. There are no prediction tools available today, but there are promising predictive variables that rely on advanced imaging. We wanted to see if we could create a clinical tool based on easy to obtain factors. So using our database, we developed a clinical prediction model with a machine learning method, lasso regression, to inform a logistic regression model, and then converted the results of the regression into an integer score, which is shown in the middle of the screen here. Higher points on the score correspond to better VNS outcome at 1 year, and the max score is 5 based on these variables that we identified. And you can see that so I've shown some ROC curves down here at the bottom. Our training sample ROC was 0.7, our validation sample was 0.62. So overall, the multivariable model was acceptably calibrated, potentially, or acceptable at predicting, but potentially a little bit lower than acceptable in the validation group. And you can see in this this graph on the right side of the screen here, that the score is relatively well calibrated towards the middle, but under predicts VNS response towards the lower end of the score. So ultimately, what does this mean? The tool is potentially usable with more robust validation on bigger samples, but we concluded that clinical variables alone are not likely to accurately predict response to VNS. And then finally, we assessed what factors could predict complications from VNS, and we split our 686 total procedures into two groups. We split it into new VNS insertions and VNS revisions. So we had a low adverse event rate as expected with VNS, and surgeries with minor complications tended to be longer than those without. Our infection rate was 3%, and the incidence rate of infection was 19 times higher for surgeries that required 2 or more prior VNS revisions. And this is important because VNS devices are not rechargeable transcutaneously. So when a battery dies, a surgical incision to the VNS pocket is required to replace the device. So for children who will likely need multiple VNS revisions if they continue with therapy, our results provide evidence for VNS companies to create transcutaneously chargeable VNS devices. So what's next? We have several projects in the pipeline, including comparing VNS to calosotomy and assessing other patient-centered outcomes following VNS insertion, like seizure-related ED visits following VNS. Thank you for your attention, and thank you. I want to give a huge thank you to all my mentors, especially my primary clinical mentor, Dr. Abel, and my statistics mentors, Dr. Jiang and Dr. Rothenberger, for all their support throughout the years. And I'll take any questions now.
Dr. Abel was mentored by Dr. Ogeman, might I add, in some strange way. So what a connection. Thank you. That was excellent. All the talks were excellent. Any questions? Anybody? Okay, I'm looking through. No hands up. Well, thank you. Go ahead. Go ahead. So, question.
There's I know there's a consortium led in Toronto to look at functional connectivity.
You broke up, Jeff.
Protocol model. Is that connected?
I'm sorry, I think I'm having a little trouble hearing.
Yeah, I think I can step in. I think what Jeff was asking about was, one of the greatest problems that we have in VNS is predicting who will respond and who will not. And right now it's quite empiric, right? We just kind of take all candidates. We tell them there's a 50% chance at 50% reduction and leave it at that. And I think he was going to bring up the multi-center consortium that's out of Toronto called the Connectivos that George Ibrahim is running, and sort of what your thoughts are on how the best way for us to figure out who will respond to VNS. How do we pick the right patient?
Yeah, that's an excellent question. And actually, Dr. Ibrahim's kind of consortium out of Toronto is kind of the inspiration for our original project. So these one of the things that they found with, like you said, functional connectivity, like thalamocortical connectivity, has been seems to be a really great predictor of VNS response. But we wanted to see if we could potentially use factors that were more easily attainable, don't rely on the advanced bioimaging, and we found that it probably isn't a great clinical variables alone probably don't accurately predict VNS response. So I think that, going forward, if we truly do want to predict response to VNS, I think we would need those, more advanced imaging data, which I think is reasonable, given that a lot of patients that undergo VNS are probably getting care at tertiary care epilepsy centers. So I think the imaging would be available. So I think that's kind of the way that we would go.